You're listening to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. Today is April 6, 2012, and I'm your host, Dr. Jay Portnoy. Our topic today, Patient Management Conference. Our presenter is Dr. Sean Stanga. He's an Allergy Immunology Fellow at Children's Mercy Hospitals and Clinics. So welcome to Conferences Online, Dr. Stanga. Dr. Stanga is a second-year allergy fellow here at Children's Mercy Hospitals and Clinics, and is going to lead us in a patient management conference. So, thank you. Keyboard. Do you have the mouse? You have the mouse. Let's take it away, Dr. Stanga.
Okay, this is a 50-year-old female who comes into the adult allergy clinic with a 6-month history of rhinorrhea and chronic congestion. She has moderate sneezing, complaining of itching, but no ocular symptoms. She was visited with an ENT recently, had a full evaluation and rhinoscopy, which revealed inferior turbinate hypertrophy and slight left septal deviation. At the time, ENT ordered a CT scan to work her up for persistent sinusitis, looking for a chronic infection. This was normal. The referral was made for allergy clinic for testing and workup. So, 6-month history of rhinorrhea and chronic congestion. Past medical history on this patient is significant for 3 times myocardial infarction with stent placement, coronary artery disease, hypertension, a little atopic. She has some mild asthma for which she's mild persistent asthma. She is on a inhaled corticosteroid controller. She has GERD, and she also has obesity. Family history is significant for asthma, allergic rhinitis, conjunctivitis, heart disease, and hypertension. Past surgical history on this patient includes a cholecystectomy. Medications for her include hydrochlorothiazide, lisinopril, topamax, and aspirin. Social, she works in environmental services. She has daily exposure to strong chemicals. These are aerosolized chemicals. She lives with 3 family members, all of whom are healthy. She's a non-smoker, and she has no past smoking history, no drug use, and no social alcohol consumption. Environmental, she lives in a house in the city. There's no indoor environmental irritant exposures, no pets, no recent water and mold damage contributing to her symptoms. On her physical exam, initial presentation, she is obese, vital signs within normal limits. Pertinent findings on her exam include minimal inferior turbinate hypertrophy, clear rhinorrhea present bilaterally, non-mucoid. Our initial workup included allergy skin testing with 46 prick application. She had positives only to dust mite, including D-Tero and D-Farina, and Roche, both American and German. She had normal positive histamine and negative saline controls. Our assessment at that time was chronic rhinosinusitis. The etiology included mixed, both allergic and non-allergic rhinitis. Vasomotor triggers were indeed noted in her history with her frequent chemical exposure. Also, looking at her medication list, we found topamax is known to cause significant rhinitis symptoms. The plan at that time was to include Nasonex, Patanase, saline irrigation, BID, and irritant trigger avoidance, of course, with her occupational exposure. That was going to be important. And switch also topamax. We instructed her to speak to her neurologist regarding finding another appropriate migraine medication.
We have some questions here.
Sure.
I went quickly here, but with the initial history, how long has she worked at the job that she has? Has anything changed in their environment or their job, and how long has she been on the topamax?
She worked at the job for about 20 years, and she's had consistent exposure to the same chemicals for the last 5 years. She uses some bleach alternatives. She uses some sterilizing aerosols. And then how long has she been on the Topamax?
Mm-hmm.
Topamax was started for migraines about 5 years ago. She hasn't had significant symptoms.
How long has she been on the aspirin?
Since her myocardial infarction, which I believe was in the early 2000s.
Can you tell me what category of drug is Topamax? Is it a beta blocker? Is it a what is that?
The seizure medication is one of the newer ones
Anti-
in the class.
Is it considered an AED? It's considered an AED.
Oh yeah, it is inhibited. Yeah, it is inhibited.
But we
But we don't know what. It's anti-epileptic. Seizure
An anti-epileptic seizure.
medication, but it's often used for chronic headaches and migraines as a prophylactic.
So is it like dilemma?
No, it's not just topiramate. Yeah,
I think it modulates neurotransmitters in some fashion.
I think so, yeah, because that helps with my headache.
So Topamax?
Yeah.
She had migraines starting about 10 years ago.
They had been up that long? I don't know.
5 years.
That was pretty new medicine.
Oh, no, it's been out. Yeah, it's been a while.
Exact mechanism of action unknown. All the AEDs.
Action unknown? Yeah.
No.
It's used for something.
That's what I thought.
That was approved by the FDA.
Only about 5 years that she's been on for Topamax. But she hasn't had any significant side effects or anything.
So is there anything that's been different or changed in the last 6 months when all this started?
She's not. This is in the middle of the winter time.
Okay, she hasn't been in any accidents at all?
No accidents. Good question.
Did you say it was unilateral or bilateral?
It's bilateral. On this initial exam, it's bilateral.
Did she have itching associated with the rhinorrhea, or was it just rhinorrhea or no?
No itching. And no ocular itching, no ocular symptoms at it.
She has about an accident because of like CSF.
Yeah.
That's good though.
No social alcohol. That's her problem. I'd encourage her to try a little. Maybe she'd feel better.
Patient returns 2 months later complaining now of anosmia, hypogesia, persistent rhinorrhea. She consulted with her neurologist. She stopped her Topamax 1 month prior, and she has no change thus far. She's still having the same symptoms. She has minimal congestion now. She has more exposure to chemicals at work, but she switched to the liquid form. She's no longer using spray chemicals, but she still is exposed to the vapors of the chemicals she's using at work. Again, the diagnosis is made for chronic rhinitis, unlikely due to allergic triggers, despite her positive skin testing, and it also being wintertime, but still she has only indoor trigger sensitivity. Anosmia and hypogesia are considered a relationship to Topamax, since these are also a known side effect of Topamax, in addition to chronic rhinitis.
Tell me what hypogesia is. I don't remember what the taste is.
Sorry, taste.
Taste?
Taste, yeah. Lack of taste.
What's the other word for that?
Topamax has a pretty extensive half-life, so that's one of the things that we were considering, the fact that maybe these senses might come back after this dissipated in her system. The plan was to begin intranasal ipratropium at this time, continue avoidance of Topamax, and she received written permission to avoid all harsh chemicals at work, including aerosolized and liquid.
Did you wear a mask?
Wasn't sure what? The preparation? No, but that's a good question. No alternative therapies were used.
She wear a mask.
We did give her a mask to wear, yeah.
No social drug use?
No social drug use. No cocaine, no intranasal.
Organic chemicals, you almost need like a gas mask with an activated charcoal filter. The kind that you use to keep pollen out wouldn't do much for volatile organics.
Yeah.
The Topamax, from what you found out from reading about it, how quickly do the side effects occur? Is it something that's been on for a long time, or does it usually occur within the first month or 6 weeks?
They usually occur fairly quickly. From what we found is they usually occur fairly quickly. So this was kind of odd, the fact that she's been on it for about 5 years in treatment for migraines, and then would develop these symptoms.
And there's no other medication, anything over the counter that she's taken that she didn't share with you?
Just aspirin. Aspirin, and then her other prescriptions for HCTV, lisinopril, and so forth. She returns again 3 months later complaining of persistent anosmia, hypogesia, and rhinorrhea, and a lot of postnasal drip now. She describes it all as clear, non-mucoid, very thin. It's never green, it's never yellow. No association with any food intake when asked specifically, looking for like a gustatory phenomenon. This is worsened by the alternate chemicals that she's now working with at work. She's using some water-based cleaners of some sort that supposedly have less noxious fumes. The interesting thing about this at this point is when we asked her how much, wanted to identify the degree of rhinorrhea. She says she's waking up in the morning and her rhinorrhea is soaking her pillow when she wakes up in the morning, which is obviously very odd in this case. She admits that at this point it's largely confined to the right nair.
You kind of told us the diagnosis now, but does she have any endocrine changes?
No. Obesity, metabolic syndrome.
No, but thyroid, cortisol, diabetes,
no history of hypothyroidism.
I mean, I'm thinking in terms of pituitary dysfunction of some sort.
No, her sugars have been normal. She's obese and she's at risk for metabolic syndrome. I think she had family history of diabetes, or sisters really had diabetes, but nothing immediate to make us suspicious of thyroid or pituitary problem.
Can you understand why I'm asking?
You're concerned about the cella turcica involves the pituitary, or concerned about like a craniopharyngioma or a tumor?
I'm thinking, things like that.
So this
Because there's
one,
no history of trauma, so I'm thinking,
right,
well, how else could that take place?
exactly. At this point, we have diagnosis of mixed non-allergic and irritant rhinitis. Suspicion at this point exists for an alternative source, since this rhinitis is refractory to intranasal steroids, systemic antihistamine, and the degree of the profuse drainage. So the plan was, at that time, we sent actually one lab, not multiple. We sent one lab and the diagnosis was made. Anybody know what that lab is?
Check the glucose on the right.
Glucose on the spinal fluid?
Yeah.
Spinal fluid.
Or on the-
It's the spinal fluid.
We actually jumped to a little bit more specific test. We did a send-out for beta-2 transferrin to ARUP laboratories, and this was positive, indicating that her rhinorrhea was consistent with CSF.
I think the glucose isn't very, what is it, sensitive?
Yeah, it's
Actually,
You can put it on a dextrose stick and
It was
see.
the Pete's resin, we just used the dextrose stick to stick it in the nose. And
Yeah.
it was high, and it's like, yeah, this is it.
That's a good formula way of testing it.
So what is,
We talked about this, I think, when that's happened, because I remember we talked about the test, I remember saying about the nose and you found this test.
what is beta-2 transferrin?
I'll actually get it.
Oh, okay, never mind. Sorry.
Another test I'm finding online called the vodka test.
Oh, yeah.
Yeah, I'm willing to do this, but azomucin precipitates in alcohol, or CSF does not.
Okay.
Even if you like collect it on a tissue, like it should dry up if it's mucus, and if it's rhinorrhea, it should just stay like watery and like the other forming stuff.
That's called a handkerchief test.
There you go. Tissue, handkerchief, whatever.
Yeah.
In light of these findings, we went back over a previous CT scan with radiology, and we talked to them specifically. They said that there may have been indication of past trauma to the head or to the face. She has slight septal deviation and some turbinate displacement, so her inferior and her middle turbinates looked a little bit funny on her CT scan. But that's, of course, that's not the true indication that she had past trauma. It's just a consideration. Neurosurgery was immediately consulted. They reviewed her MRI in 2008, which was obtained for eye pain, and it was unremarkable. There was no cortical breaks, there's no sinus disease noted, and so they ordered a repeat MRI, which this time revealed fluid in the right sphenoid sinus. This was present as an air fluid level, and so the suspicion was made for a CSF leak into the right sphenoid sinus. She had no obvious cortical breaks, but the suspicion was for previous head trauma versus a spontaneous CSF leak, which I'll talk about. Patient underwent a transsphenoid repair of a CSF fistula in the sphenoid sinus with what they used was a fat graft and the placement of actually of a lumbar drain. Patient has risks associated with any kind of surgical correction like this, and that includes, these were specifically gone over with neurosurgery, bleeding, transfusion from bleeding, nerve injury, brain hemorrhage, stroke, facial paralysis, loss of vision, speech, or continued fistula. So it's not a surgery to be taken lightly. Her repair in this case was successful. However, unfortunately, she had multiple operative complications. She developed tracheal edema with resulting subglottic stenosis. She had to have a tracheostomy. I saw her in pulmonary clinic weeks later for asthma, and she still had her trach. She has persistent headaches now and suffers from recurrent epistaxis, probably from the manipulative bleeding. Yeah, but you have to consider your risk versus your benefits, and the risk of meningitis occurring with an open portal to your dura is pretty profound. So she's presently being followed with neurosurgery, and she has a repeat CT scan pending for her headache and her epistaxis.
I can't imagine that's a very straightforward operation.
No, it's not. It's an endoscopic evaluation through the sphenoid sinus. Of course, they have to go all through the entire ethmoid folla and everything to reach the.
I can't imagine. It's just got to be amazing.
So we're going to talk a little bit about the types of leaks, basically. This spontaneous cerebral spinal fluid leak can be classified as either idiopathic or traumatically induced leak. CSF leak can cause symptoms of dizziness, nausea, fatigue, sometimes even a metallic taste in the mouth due to the perception of the salty taste of CSF in the mouth and the tongue. You can get some tingling, some facial nerve involvement. It's often repaired by an epidural blood patch or a fibrin glue injection. Or in this case, they opted to do surgery since they felt that the leak was profound enough to go in transphenoid. It occurs in about 5 out of every 100,000 people, and particularly affects women. The early 40s is the predominating population. Spontaneous leaks usually present with a sudden severe headache, and this is actually an orthostatic headache where the headache is much worse when the patient is vertical and less severe when they're horizontal. Sometimes CSF can be observed as discharge through the nose, in this case, or through the ear, especially after trauma. Often CSF leaks can easily be identified as this second half of the day headache. The patient presents with a headache in the afternoon as opposed to in the morning. Lack of course, CSF pressure in the volume in the brain can allow the part of the cerebellum to descend through the foramen magnum, causing a slight herniation and pressure on the cranial nerve complexes. So the patient can actually come in with some sensory symptoms of cranial nerve deficits as well, even in the absence of trauma. So there's two main theories associated with spontaneous leaks, and this is not including trauma. Of course, trauma would be number one on the differential if you have clinical history consistent with that. But as far as spontaneous leaks are concerned, connective tissue theory, spontaneously or from an unknown cause, usually these people have some type of underlying connective tissue disorder that has not been previously diagnosed, or they had not previously expressed those traits associated with connective tissue disease up until this time. 2/3 actually of those afflicted with spontaneous leaks demonstrate some type of previously undiagnosed underlying connective tissue disorder. Those patients that are afflicted with Marfan syndrome, Ehlers-Danlos, and autosomal dominant polycystic kidney disease are more prone to having spontaneous CSF leaks. There's also a spinal drainage theory, which has to do with an abnormal spinal venous drainage system, which somehow may precipitate a CSF leak. Up to 94% of spontaneous leaks are initially misdiagnosed. The incorrect diagnoses are often migraines, meningitis, and psychiatric disorders. Average time from onset of symptoms is about 13 months until the diagnosis is actually made. You can use various imaging techniques. Usually the diagnosis is made with an MRI using T2 heavyweight MRI, but you can also use CT myelogram, where opening fluid pressure is measured via lumbar puncture. Radiopaque contrast material is injected into the spinal fluid, and then you see the contrast diffusing out these dural holes wherever the actual CSF leak is. And you can identify that with CT myelography under fluoroscopy. And of course, the alternative weight is T2 weighted MR myelography. This avoids, of course, the need for lumbar puncture and further exposure to radiation. Another potential test that we did is a simple send-out. It's for beta-2 transferrin in the CSF, or the suspected leak that you have. Beta-2 transferrin is a isoform of transferrin that's actually found in the CSF, but it's not found in blood, mucus, and tears. A specific marker of CSF, and it can be applied in any cases where you have CSF leakage suspect, but obviously not in the case of trauma or history of trauma. You're not going to send out this test. It took about 2 or 3 days to come back from Salt Lake City. A more rapid test would be something like a glucose or a dextrose stick. It's an interesting case, something to keep in mind when you're just treating allergic rhinitis. And gustatory or chronic vasomotor rhinitis is not always going to be associated with some irritant or allergic disease of the nose. This lady actually, about a week after her repair, we were in touch with her, and she actually, we inquired about trauma, and she initially denied any trauma, but later she remembered this time that she was actually out somewhere outside of her house and slipped and fell and may have hit the front of her head. Although it was minor trauma, it may have been something enough to cause a shear or some type of a break in the cellulosica with the sphenoid.
Isn't it usually supposed to be unilateral, or do you know?
It's usually unilateral.
Do they say why hers was bilateral?
So she initially presented with bilateral. It may have been some initial rhinosinusitis. It may have been like irritant rhinitis or something.
She just didn't notice it.
Yeah, she just didn't notice it. On the initial exam, she definitely had bilateral rhinorrhea. There was no more weight on one side versus the other.
And it worsened, right?
And then it worsened. Yeah.
Got to the right.
Over time, this was over like a 5-month course of repeat visits, and over time she just became more profuse, especially once she told us that it was starting to soak her pillow at night.
Yeah.
So anything that's refractory to, nasal medications or systemic medications, you should always consider this as a possibility, especially if it's unilateral, but I suppose you can have a bilateral nausea too if it's severe.
Well, sometimes you may not ask that. We may not say, like, is it worse on one side or the other?
Right.
They may not think that's important to tell you. I think it's a good question.
Right.
Well, and it might be midline, and then it would be both sides. But why did she have the lack of smell and taste? Did it damage the nerves, the cranial nerves that are connected?
That's a good question. We talked about that later. We were thinking maybe it had to do with the Topamax. When we talked to her later, when I saw her later in the pulmonary clinic, it's improved a little bit, but she still has some lack of smell and taste. I don't know if there's any particular association between CSF leaks and loss of taste and anosmia in particular, but.
Well, that's why I was thinking maybe a tumor in the tooth area, in that area that eroded and finally broke through and caused a leak, but would also be interfering with their olfactory nerve and those type of visual changes and pituitary and so on.
Having like damage to their peripheral plate.
That's nothing that was visible on MRI or CT. The whole cell at Cercica was intact. They couldn't see any obvious cortical breaks on the actual scan, but they suspected it was something that they couldn't see, some type of a very minor fracture that was just causing leak that possibly just, was give enough shear force to cause a break or affect the dura in some fashion.
Any idea on the cost of the beta transparent test?
The cost? I don't want to know.
I'm always curious. I don't know.
It's a medical test that costs a lot.
Yeah. I mean, in general.
Send out like that, yeah.
Don't they all? Let's see, Bach, did you want to comment?
Yeah, I was just wondering if she had problems with her ears. Does she have any problem balance, this sort of thing? Because beta-2 ferritin is also found in the inner ear perilymph.
Yeah, beta-2 transferrin found in perilymph also. That's a good point, Brock. No, she didn't have any balance problems. I don't think any of this leakage out her nose was associated with any rupture inside of her ears or anything. That's a good thought. So that's something else to consider. If you have otorrhea, you're going to need to think about damage to the middle or inner ear with perilymph leakage, because beta-2 transferrin is also found in perilymph.
Okay.
If you're worried about the pituitary on exam, you can check for it by temporal hemianopsia too. It's like where the optic nuclei are. So if you lose your lateral field, you can go to your field state test. If you want to actually do an exam test for the pituitary issue. Well, that's all I know about ophthalmology.
We've now heard the full extent. We're digging deep into our memory of these things that we forgot from medical school. Even deeper. Okay. Anything else? Any other comments or questions from the group? We've got a break then.
This has been an ACAAI production. To learn more about Conferences on Lyme Allergy or the American College of Allergy, Asthma, and Immunology, go to www.acaai.org. See you next time.